Presentation of Dialogue on Idaho Public Television is made possible through the generous support of the Laura Moore Cunningham Foundation, committed to fulfilling the Moore family's legacy of building the great state of Idaho.
Coming up on Dialogue, hospitals are major players in healthcare reform discussions on Capitol Hill. So what do they stand to gain and lose from potential changes to our healthcare system? We talk with the CEOs of Idaho's two largest hospitals and take your phone calls next. Stay tuned. Hello and welcome to Dialogue. I'm Marcia Franklin. A welcome as well to those of you listening on public radio and the World Wide Web. More than 20% of the people who check into hospital emergency rooms in our country have no insurance. That's more than 24 million people a year. And the average cost of treating each of those patients has risen to more than $19,000. That situation, among many other variables, has meant hospitals have taken a keen interest in healthcare reform discussions in Congress. Last July, three major hospital associations announced they'd sign on to cuts in Medicare and Medicaid payments to the tune of $155 billion over the next decade if lawmakers came up with a bill that would cover at least 94% of Americans with some basic insurance. Now, in exchange for that concession, hospitals are asking for some benefits on their side of the ledger, too, which we'll discuss. But of course, all of this is in flux as lawmakers try to reconcile several different pieces of healthcare reform legislation, including a House Democratic bill that Speaker Nancy Pelosi announced Thursday. So how do some Idaho hospitals view the latest versions of healthcare reform? Tonight, we're joined by the chief executive officers of Idaho's two largest hospitals. Dr. David Pate is the CEO of the St. Luke's Healthcare System. An internist by training, Dr. Pate became a hospital administrator in 1995. Prior to joining St. Luke's here, he was senior vice president of St. Luke's Episcopal Health System in Houston, which is not affiliated with the Boise St. Luke's. Now, with more than 7,600 workers, St. Luke's Health System is the largest private employer in Idaho. It operates hospitals in Boise, Meridian, Ketchum, and Twin Falls. Welcome to you, Doctor.
Thank you. Glad to be here.
Also here with us is Sally Jeffcoat. Ms. Jeffcoat is the new CEO of St. Alphonsus. Prior to taking her current job, she was the chief operating officer of Ascension Health, which is operated out of St. Louis. And St. Alphonsus employs about 3,500 people, and its parent company is in the process of purchasing Mercy Medical Center in Nampa and two Eastern Oregon hospitals. It's nice to have you here.
Thank you. Glad to be here.
Now, do you have questions for my guests on how hospitals operate or thoughts on how hospitals could restructure their services during healthcare reform? Give us a call at 1-800-973-9800. Well, first of all, welcome to Idaho.
Thank you.
To both of you. And both of you knew each other before, which I think is so interesting. You worked together, at competing hospitals in Houston?
Right.
So you're friendly competitors already?
Yes.
Exactly.
Exactly.
And we found out before the show that it sounds like you're going to be neighbors as well.
We are.
That's right.
We just learned that, actually.
Well, it's great to have you both here. Let's jump right into this. As I mentioned, Speaker Pelosi has announced a House Democratic plan. We have a Senate plan on the table. We're moving towards debate. What do you think about these bills? What's your thoughts? Do you like one over the other? Do you like the direction that they're going?
Well, certainly both of them have good points. Both of them have concerns for us. I think the biggest problem that I see with them is it doesn't really address the ultimate issue. The ultimate issue is, first of all, none of the bills really insure everyone, as you mentioned in the introduction. So that's still a problem. The second thing is these bills really focus on insurance reform or payment reform, and what we believe is that healthcare really needs to be transformed. And we've got to do things differently. We've got to get costs out of the system. We've got to make it more efficient. And in my opinion, these bills don't get us there.
I would agree, and would add that what I'm, optimistic about is that we've moved in the right direction with the House bill today. We get to 95%, 94% coverage. It still needs to go higher, we believe. The reimbursements to physicians and hospitals has to be seriously looked at, especially the physician payment fix, which is very important. But we're still concerned about what the hospital reimbursement will be. In terms of care delivery, we think that that's where reform needs to happen, because we can't really squeeze the costs out of the system unless we transform the way we deliver care. And that's going to take some creativity. It's going to take some investment up front by Congress to create some of the pilot programs, investing in electronic health records to really transform the care.
Well, before we go any further, maybe I'll just ask you kind of a philosophical question. Do you believe health care is a right?
It's a great question. You know, from a legal standpoint, it probably is not. From an ethical, moral issue, it probably is. And I think the question, the tougher question, is actually what degree of health care. And so, I do believe everybody ought to have access to health care. But, we've got to address some really tricky questions. Does that mean all health care? And who gets to decide how much health care that you get? And what about end-of-life issues? Another big issue that's not addressed by any of the bills is undocumented aliens in the country. And that's a significant burden on hospitals, one we take on because we do believe people should have access to care, but we're not taking care of everyone, and it's a real issue.
Healthcare a basic human right to you?
St. Alphonsus is part of Trinity Health, is a Catholic healthcare organization. Our position is that everyone should have access to care, and coverage is very important. So insurance coverage is key to having access. We believe that everyone should have a standard benefit, much like Congress and federal employees have. And so that basic level is very important to think about and to fund from a national point of view.
We saw a picture right there, this is from a NewsHour piece, just went by, of Congressman Minnick, a Blue Dog Democrat, and the Blue Dogs obviously have been negotiating some of this with the Speaker. Does your view that health care is a basic human right translate into support for the so-called public option that we're seeing, whether it be watered down a little bit in these latest bills, but does that mean you like having a public option?
We are neutral on the public option at this point. We think there needs to be much further review and analysis of that option. And I think what's most important is, can we create the kind of expansions in coverage to get us most of the way? So the employer provider, the employer coverage, as well as individual mandates, and shared financial responsibility is very important to really reform the coverage issue.
And your sense about the so-called public option, the government providing an option for people to purchase insurance?
Generally very reserved about it. I think it also depends on what they really mean by the public option. That's gone through some evolution. Today's version in the House bill is a different version of the public option than what has been proposed before. What we definitely are not in support of is a public option that bases the reimbursement rates off of Medicare.
Well, it seems like the hospitals have been successful in their lobbying attempts. The public option looks like, at least in the House bill, that hospitals will be able to negotiate those rates and other providers as opposed to them being set. Is that correct? And was that part of the deal that I mentioned up front, where hospitals would shave $155 billion off of their reimbursements if they got this provision?
Well, it wasn't as much on this point. It was more on getting people insured. And what levels, as you said in the introduction, I mean, what the American Hospital Association said is we want to see at least 94% of people insured. Now, that has not happened with the Senate bill yet. They're below that threshold. It does happen with the House bill. But the real problem is that the Medicare system, and frankly the Medicaid system as well, so the state and the federal programs, are not bearing their full weight of the costs of health care. And what that does is it causes shifting to private payers, or if those aren't available, it threatens the viability of hospitals. So if we have a public option that's based off of that as well, and even extend it, it could tip the balance, and many hospitals that are just hanging on and that we count on for critical access and safety nets could go under.
But it appears that the hospitals have been successful in at least getting this provision that those rates will not be set in the public option, that you'll be able to negotiate
Those rates. That's correct.
And if more people are covered, presumably then your bad debts will go down and your charity care needs will go down, so you'll be making more money?
Well, I think that's where Dr. Pate is saying the 94% coverage is where we needed to get to in order to sustain the cuts that we were projecting, the $155 billion in cuts. So there's, coverage is better, but it depends on where those negotiated rates really land. The other thing that is an issue is the expansion of Medicaid to 150%. And that is, if we're not receiving the full benefit of cost on the Medicaid side, then it further burdens hospitals as well.
Well, I think you're saying is that Medicaid is a federal state program,
right?
Match program, and if they, as you said, increase the eligibility for Medicaid, which seems to happen to increase coverage, the states have to ante up some money too. And Idaho has been notoriously frugal with its match money.
That's right.
So that's concerning to hospitals, is it not?
And I think the reason why we have some caution about it is because we need to really understand what is the state's long-term responsibility to bear that burden of expansion of coverage. And the federal government really has to be fiscally responsible and be good stewards of how they're going to push that back on the states.
We've got a question that came in on our Facebook page, and I really appreciate this. I encourage you to go to our Facebook page, Dialogue on Idaho Public Television, and become a fan. And Benjamin writes, with the way the opt-out public option looks, and that's the Senate version, it's doubtful if Idaho would ever participate. Given that factor, what will the CEOs do to provide more charity or low-cost care to those who are in the lower income brackets?
Well, I think, first of all, I don't know that that's exactly clear. So first of all, back to Sally's point on the Medicaid, increasing the Medicaid eligibility to the 150% of poverty level. The problem is the state still has to come up with money. And that's irregardless of what happens with the opt-out provision that's being suggested right now. Frankly, the state budget, as I understand, is already in deficit, and so where is Idaho going to come up with the additional money to fund this? As Sally was saying, that the government has said, well, we'll take care of it for a couple years, but then it's going to fall on the states. So we have that issue. As far as charity care, I think both of our institutions provide a great deal of charity care, and so that will continue regardless of what happens. In terms of low-cost care, that's what Sally and I are talking about, that healthcare reform doesn't address, and unfortunately that just leaves it up to our institutions to continue to try to drive cost out of the system. But the other thing you have to remember is if we add more people to this, now they have the insurance, typically what happens is utilization of services increases. That can drive costs.
Let's take a phone call from Patricia in Boise. Patricia, go ahead, please.
Hi.
Hi. Go ahead.
My question to these two CEOs is this. Why is there duplication of services?
Okay, great question.
St. Luke's, excuse me, I'm not done yet.
Okay.
St. Luke's was noted for pediatrics and for maternity, and St. L's was noted for trauma and emergency room care. Now all the hospitals have expanded, and I feel it's duplication.
Great. It's a great question. Let's get to it. When I told people that I was doing this program, that was the number one question that came up. Ask them why so much expansion. I'll start with you because St. Luke's, in the time that I've been here, has expanded its downtown facility, Meridian, it's built Wood River, Magic Valley, and all sorts of other ancillary services. So,
well there's many reasons for that. First of all, since the time both of our organizations started here, Boise has gone through tremendous growth. Frankly, our community could not be served by either one of our hospitals alone. The other thing is, in years past, we did try to avoid duplication. In fact, the hospitals worked very diligently, as the caller was talking about, to decide who was going to offer what services. Problem is that is illegal. The government antitrust laws actually prohibit doing it. It would make sense for this community, but the idea on the part of the federal government is they want to promote competition. So we have to do that. The second thing is, I think managed care has necessitated this. What managed care wants and what people want and employers want is access. They want many access. They want choices. And so we've had to respond to that as well.
You are a not-for-profit hospital. You are a not-for-profit hospital. The other question I get from people is, they're not-for-profit. Why are they spending so much money on expansion of services? They must be making a profit. I think it was something like $90 million in capital expenses for St. Luke's. Your parent company is looking at purchasing 3 more hospitals. How can you be a not-for-profit?
Well, I think one of the challenges with healthcare reform and the need to reform care delivery is creating integrated delivery systems where physicians and hospitals and ancillary providers come together and provide.
Holy Rosary, by the way, of which you're thinking of buying, I think.
Yes. So part of the challenge there is to create efficiencies. We have to expand and to deliver care where it's appropriate in a community. So one of the reasons why Trinity is in negotiations with Catholic Health Initiatives to purchase the 3 hospitals is so that we can create a regional system, much like St. Luke's has done over the number of years. And the redundancy or the duplication of care that's occurred over the years, I think is purely driven by the market. I think the managed care companies want a full continuum of care, and so we've had to respond to do that. However, with healthcare reform, we also need to look at ways to collaborate and to eliminate redundancies as much as possible. And I think we are definitely getting there. I know that since I've been here, I've gotten a lot of feedback about the past competitive nature of the 2 institutions or health systems, and I see a lot of progress that we're making towards eliminating redundancies, cooperating in care delivery in this community.
What about this not-for-profit issue?
Right.
How can you, if you're making money, clearly.
It's a misunderstanding. Not-for-profit has to do with who are the owners. And not-for-profit organizations are owned by the communities as opposed to for-profit organizations that have private investors. The thing is, everyone should want not-for-profit organizations to make more money than their expenses, because if they don't, the not-for-profit organizations will go out of business. It's what we do with the profits. Instead of distributing them to shareholders or other owners, what Sally's organization and my organization do is we plow those excess dollars over expenses back into our organizations. And what is really one of the key things is it is very expensive to try to keep up with the kind of technology that the citizens of Idaho would rightly want to have. We need to make those investments, but they're very costly. We have to generate money to make those investments.
But you were talking about hospitals needing to take responsibility for cutting costs
right.
as well. So wouldn't
operating
that be,
costs.
Okay, not in purchasing
So
machinery.
that's different.
And let me just ask you before we go to phone calls, because we got a lot holding. You are also tax exempt.
That's right.
Because you're not for profit. Well, partially.
One doesn't necessarily follow, but yes,
right.
we are both
but
tax
you're tax
exempt.
Right. So why is that important? You don't pay property tax, you don't pay income tax. That would be giving money back to the state. Why do you feel it's important to stay tax exempt?
Because we reinvest all of the revenues over expenses back into the community. So we have, beyond providing charity care, we have many programs that really improve the community health and reach out to those who are underserved and are in need of care. So in order to do that, to do that to the degree that both St. Luke's and St. Alphonsus do, I think it's justifiable to be in a not-for-profit situation.
I have a question that came in also over the Facebook from Eleanor. She wants to know, first of all, how is charity care service apportioned? Who gets it, and based on what criteria?
From the standpoint, first of all, how we provide charity care depends on who's accessing our health systems and for what. But basically, the basic approach is to determine whether people are qualified. We all have
On the front end.
right on the front.
they
Well,
come in.
if it's an emergency situation, we provide the care without making
Right.
that determination.
And but if you start to bill them, it's no longer considered charity care, right?
Right. If we expect payment, that's not our charity care.
And what is the qualification for charity care?
Every organization has a criteria for charity care, and it's based upon poverty, the federal poverty levels, and that's where we qualify somebody who is, and it's a sliding scale based upon that, how they qualify against
One of
poverty.
the provisions of the House bill I noticed was to be more transparent with letting patients know what your charity care provisions are. This might help this person, Eleanor, who wrote, she said, I'm self-employed and support myself without any state or federal assistance on income that's between $20,000 and $25,000. She's had to go to the emergency room a couple times, both at St. Luke's and St. Alphonsus. She asks, why does St. Luke's immediately turn over my emergency room bill to collections agency with accompanying penalty and interest? She wants to pay her bill. On the other hand, she said St. Alphonsus has billed me directly, and as far as I can determine, does not attach a penalty. So I guess the question is more for you about why some things are immediately going to collections without giving the person an opportunity to pay.
Yeah, it shouldn't. If that's the case, it shouldn't, and she needs to contact someone in our billing office because we don't do that. But basically, again, what we do is we determine whether somebody falls within the guidelines of charity care. This person may very well not. And so in this case, what we would do is work with the patient, and the patient just needs to talk to our billing office.
Okay, let's try and get to some phone calls. Let's go to Mike in Wilder. Mike, go ahead, please.
Yeah, is malpractice insurance a big part of your budget? And number two, would a ceiling cap on settlements bring your costs down?
What was the second part, please?
Would a ceiling cap on
Okay.
all settlements bring your costs down?
Thank you very much. How much part of your budget is malpractice insurance, and do you think there should be a cap?
You know, we do have malpractice is a very big part of any hospital's budget, and again also for our physicians as well. That's one of the things that we have tried to push for in the reform packages to also have the malpractice reform. The question about would having caps help? Yes. What we support is caps on non-economic damages. People that have economic harm should be fully compensated. It's a question of what is going to be paid above and beyond that.
Okay, let's take a call from Brian in Jerome. Brian, thanks for holding. Go ahead, please.
Hi, I was curious. Earlier in the show, you mentioned that 94% was covered in this new plan, and then it needed to be higher. What's the other 6% that wouldn't be covered in
Great.
this plan? Are
Thank-
they working American citizens?
Thank
or-
you.
Thanks.
Thank you very much. Where does the 6% come from?
Yeah, actually, just to correct the statement, what we were talking about is, and not that the House bill, which gets to 96%, isn't agreeable to us. We are agreeable with that. It was the Senate bill that got to 91%.
So he's just wondering where.
But where the rest of it is in a lot of different areas. Some of these are people that, like the person the other caller you said, who makes too much, who is not eligible for a charity, but not enough that they, or works for a solo employer or small employer that doesn't have insurance. The other thing is, we talked about none of these numbers include the undocumented aliens.
Right.
Some of these are children that are U.S. Citizens. They're here properly, but their parents are not documented aliens.
And the other aspect of this is with the individual coverage, the mandate around that.
Yeah.
It'll be interesting to see how those bills go through, because that will float that number up or down.
This is going to be very interesting. Both bills require everybody in this country
Right.
to have insurance of some type, or they'll be penalized on their taxes. And they can get help through the government, they can get help through their employer, but they must have insurance similar to the way we all carry insurance on our cars.
Right now, the 94%, I believe, is about 25 million people in the U.S. will not be covered. And it's made up of all the categories that you talked about, David.
Okay, let's take a call from John in Boise. John, go ahead, please.
Hi. By most appearances, both organizations appear to have a massive marketing budget, but most specifically St. Luke's. And I'm curious how marketing so heavily benefits the mission. I mean, the local television channels and newspapers are just replete with advertisements from both organizations, and they're basically monopolies in many communities.
Thank
So
you.
what's
Thank you
the
for your
purpose?
question. Thank you. A lot of marketing dollars.
Right. Actually, I haven't looked at that thoroughly yet, just in the time that I've been here, because I've had some other priorities. But my impression is that the marketing budget is much smaller than what most organizations is. Marketing is still important, that we do need to make people aware of services that are available. And so it is a part. I don't know any organization that doesn't do marketing. I think what we try to do is be responsible with those marketing dollars.
Did you want to respond to that?
Well, I also believe that as new programs are developed, the community needs to know about that. As new physicians come into the community, it's important to let the community know that they're here.
We have just about a minute and a half left. Do you think reform will occur?
I think it is much more likely than it was a few months ago. I really was skeptical. I think there's a good chance it will occur, but I don't think it's a given.
I didn't think so at first, but I'm very optimistic now. I do think this is not a short-term process. It's a decade-long process, and I think it's going to take a lot of work on all of our parts to make this happen.
Well, I want to thank you, and for the callers that are still holding, we will take your calls. Just stay on the line, and we'll do that, and we'll record that as one of our web extras. And there's additional information on our website. We've got a great website with more information. It's got all the side-by-side comparison of the bills, if you want to be a geek and read about them like we do. And I really appreciate both of you coming on for the radio audience. You've been listening to Dr. David Pate. He's CEO of St. Luke's Health System, and Sally Jeffcoat is CEO of St. Alphonsus. And thanks as usual for tuning in to this edition of Dialogue. We hope you'll join us same time next week.
Presentation of Dialogue on Idaho Public Television is made possible through the generous support of the Laura Moore Cunningham Foundation, committed to fulfilling the Moore family's legacy of building the great state of Idaho. To order a copy of this program from Idaho Public Television, call our toll-free number or visit us on the World Wide Web.